Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by gastroenterologist Dr. Aline Charabaty, who is an assistant professor of medicine and the clinical director of the Gastroenterology Division, as well as the director of the Inflammatory Bowel Disease Center at Johns Hopkins Sibley Memorial Hospital. And today we're going to be discussing inflammatory bowel disease, also known as IBD. So welcome, Dr. Charabaty, and thank you for joining us today.
Thank you for having me, Lillie. I'm very excited to be here and to talk about a topic very dear to my heart, inflammatory bowel disease.
I have to giggle when I say it's near to your heart, because I think if you had inflammatory bowel disease and there was a way to get it in your heart, it probably would be called tachycardia. So inflammatory bowel disease, some of our listeners, the majority of which are women, probably have seen this term IBD on television because there's various commercials today for all kinds of illnesses and disorders. And so they probably know that it's pretty common, but they probably don't know much beyond that. I know that it has been used to describe a set of two chronic diseases of the intestinal tract, Crohn's disease, as well as ulcerative colitis. But according to the Crohn's and Colitis Foundation, is it true that there's about 1.6 million Americans who have now been diagnosed with this disease, and that the majority of them are diagnosed before the age of 35?
Yeah, so inflammatory bowel disease, or IBD, is actually on the rise. So it was initially described at the beginning of the century, but over the course of the recent years, we are seeing an increase in the incidence of IBD. What does this mean? We're seeing more diagnoses of inflammatory bowel disease, and not only because we're recognizing this disease and we have better tools to diagnose it, but also there's probably something going on in our environment, what we're eating, the way we're living, our gut microbiome. There's so many theories and thoughts about why this is happening, but we are seeing an increase in the incidence of inflammatory bowel disease, not only in westernized country where we typically see IBD, but also in other parts of the world where IBD used to be uncommon. We are seeing an increase in the incidence of inflammatory bowel disease when these countries become more westernized. In the US, we also are seeing an increase in IBD in communities, again, where IBD was uncommon. When I went to med school, which is not too long ago, IBD was typically a disease of Caucasian, of people from European descent, and mainly seen also in Ashkenazi Jews. Now we are seeing an increase in the incidence of IBD in all ethnicity and races. High increase in the Black community, in the Hispanic community, and in immigrants to the United States.
Do you think that it's still currently underdiagnosed?
So that's a very good question. And again, there are many answers to that. So like you pointed out, it typically starts in young people, in the adolescent, in young adults, but we also see another peak in older patients, but it also can be diagnosed throughout someone's life. Okay, so it's not uncommon to have a diagnosis of inflammatory bowel disease at age 60 or 70 or any time. So because we think of it mainly of disease of young people, often it can be overlooked when symptoms start at a later age or could be mistaken for other pathologies. That's one. Two, in terms of symptoms, how it presents, it really depends on what type of symptom the patient has. So inflammatory bowel diseases, like you pointed out, Crohn's and ulcerative colitis, are diseases where there's active inflammation of the gut. So when we look at the gut with a colonoscopy, we see redness, edema, ulcers, bleeding. So there's inflammation. But this inflammation can be of different degrees and affect different area of the gut and hence cause different symptoms. So typically when a patient presents with, let's say, bleeding in the stool, people take that seriously, right? They go to the doctors, and often doctors take that seriously and they get the right workup. But when people present, let's say, with abdominal cramps and diarrhea, often they are misdiagnosed, and often women get misdiagnosed as having irritable bowel syndrome or lactose intolerance, or this is just stress, something you ate, something didn't agree with you. So there can be a misdiagnosis there. And then one of the other reasons why it could be underdiagnosed is the ethnicity of the person presenting with symptoms. Like we said, we typically think of it as a Caucasian disease, an Ashkenazi Jewish disease. But when you have an immigrant from a country where IBD is uncommon, for example, someone from South Asia or from the Middle East, we often don't think about it. And so there could be a delay of diagnosis there.
And thank you for making the distinction between IBD and IBS, because I'm sure that our listening audience hears a great deal also about IBS, and there certainly is a difference between these two. Is IBD an autoimmune disease?
I want to kind of circle back to the IBS because I know a lot of women listening here, and IBD affect commonly men and women, maybe a little bit more women. IBS seem to affect more often women, or at least women have a tendency to seek care. And it's important to make that distinction. There's often confusion because there's two common letters. And IBS can present with abdominal pain and diarrhea also, like IBD. But the difference is in IBS, when we look at the colon, when we look at the gut, everything looks normal. So irritable bowel syndrome is a syndrome as opposed to a disease where there's different symptoms. But when we look at the gut looks healthy. And the reason behind IBS, it's not in your head. You're not imagining that you're having abdominal pain and diarrhea. We're really starting to understand what IBS is. And it's probably a combination of change of the gut microbiome, how your gut moves, the sensation of the gut, how your gut reacts to certain things. But I do want to point out to our listeners, and if there's anybody out there with inflammatory bowel disease or with IBS, that these two conditions can actually coexist. People living with IBD tend to also have more IBS. Imagine if your gut has been inflamed and beaten up. Even when we heal the gut with the medication that we have, your gut is going to become irritable. It kind of makes sense, right? If you've had a rough day, you're irritable at the end of the day, right? And same thing happens to your gut. If it's been inflamed, but by the time we diagnose this, treat it, and your gut heals, the gut can become irritable. And so many people with IBD, once their IBD under control, they can also suffer from IBS. Well, they have the cramps, the diarrhea, the urgency without having inflammation of the gut. So it's important to recognize that. In terms of what IBD is, what is the reason? We don't consider it as a pure autoimmune disease. The cause behind IBD is likely very complex. And it's a combination of genetics. So you inherit some genes that increase the risk of IBD. If you have a mother or father or family history of IBD, your chances of IBD is increased relative to the general population. Someone who has a parent with IBD, their chance of having inflammatory bowel disease is around 3 to 5%. It's not 50 or 80. It's still higher than the general population. So there are some genetic component, but that's not the whole story. The second thing is that we do understand that the gut immune system is dysfunctional. It might not defend itself from some exposure in the gut. Everything that we put in ourselves, right, is exposed to the gut immune system. So the gut immune system might not respond well to certain, what we call environmental exposure, right, what's in the gut, and might overreact, cause hyperinflammation that just keeps on going. And we're understanding more and more that the environment plays a role, right? So for example, smoking increases the risk of Crohn's disease, increases the risk of complication from Crohn's, the need to have surgery in Crohn's disease. But other environmental factor that we're looking at now is diet. There was a recent study showing that the more you eat processed and ultra processed food, the higher the likelihood of developing IBD in the course of your life. What do I mean by that? Anything that comes in a bag or in a box, anything junk food. So we live in a society where it's just easier to grab a burger from a fast food restaurant and have cereals as opposed to oat, home prepared oat. All these things coming in a box, in a bag, that's ultra processed food. There's also some recent data that overuse of antibiotics can also increase the risk of developing IBD. And it seems that a lot of these environmental factors, at the end of the day, it boils down to how they affect the gut microbiome. We have in our gut trillions of bacteria and fungus and virus that we live in harmony with. And if we...
That's going to be a surprise to our listeners, by the way.
Well, we talk a lot of like probiotic and yogurt and everything. So microbiome is becoming like the hot gut topic, right? I was saying IBD is dear to my heart. Probably I should say it's dear to my gut. It's really these trillions of organisms that we live with. We have actually more bacteria living with us than we have cells in our body. So if we have a healthy microbiome, it actually promotes a healthy gut. And when we start losing the good stuff, the good bacteria, virus, fungi, or when they start to be inactive, that create an imbalance, right? An imbalance of what the type of bacteria that cause more inflammation compared to the bacteria that decrease inflammation. And that can contribute to developing IBD. Again, not everything works for everyone, meaning some people have more of a genetic component, likely those that are diagnosed very young. Some people where the environmental factors are more important. So it's this whole interaction that's happening in our gut that creates inflammatory bowel disease.
And we don't want people to think if they've had one episode of abdominal pain and diarrhea of, oh my gosh, I've got IBD, because they probably did eat something that was not to their liking. At least their gut didn't like it and said, I'm getting this out of here.
Absolutely.
I'm not going to keep it in here. A lot of people, will turn to self-diagnoses and medication over the counter. You see probiotics advertised on television. You go into any pharmacy and you've kind of got to walk by them to get back to the pharmacy. Is it okay if someone starts taking a probiotic, or should they be having a conversation with someone like you before they start self-medicating?
In the context of inflammatory bowel disease, it's very important to realize that we live in a very, very lucky period of time where we actually have effective treatment for IBD. It's very important for people living with IBD to understand that under-treating IBD, not treating it properly, can really lead to complication. Anywhere from the symptoms of pain, diarrhea, bleeding, to developing anemia, osteoporosis, broken bones, complication outside the GI tract. IBD can be associated with joint pain, with certain skin lesion, with liver disease, and complication of the gut, where the gut can narrow down and cause blockage, or you can develop an abscess, and all these complications can need surgery. So it's very important to have the mindset that instead of thinking, oh my gosh, I need to be on medication for the rest of my life, to think, oh my gosh, we are actually living in a period of time where we have effective treatment, because 30 years ago, all we had was prednisone, which increased the risk of infection, of breaking your bones, of having disfiguring physical changes, high blood pressure, diabetes, horrible things to be on long-term, or we had surgery. These were the only things we had. So we're lucky to have medication. Now, am I open to other things? Absolutely, right? But it's important for us to discuss that with your doctor, because we need to know what you're taking, making sure interaction with other medication, making sure you're spending your money on the right stuff. There are tons of probiotics, and it's important to choose the right probiotic for the right condition. If you read the labels on these probiotics, each one of them has different type of bacteria there. And we all know we need specific type of medication or bacteria to treat specific condition. In terms of when we bring it back to inflammatory bowel disease, do we have good data on probiotic and IBD? And actually the data is very mixed. We don't have very good data on Crohn's disease. Doesn't seem to help. Certain type of probiotic help with ulcerative colitis. So that's why it's important to discuss with your doctor and to learn what is that specific type of probiotic that can help you when you're spending your money there. But beyond that, and I do understand that people want to know, like, I'm doing something for myself to contribute to a healthy gut and to contribute to healing my IBD. The advice that I give people is, if you're taking a probiotic and then opening a bag of potato chips and a hot dog, it's not going to work, right? It's not going to work.
Canceling out one another.
Right. It has to be part of a whole lifestyle. I'm going to sleep well. I'm going to do a physical activity that my body allows me to. If you're feeling tired and sick because you're in the middle of a flare, I'm not going to ask you to run 5 miles. But as you're feeling better, incorporate a physical activity and really incorporate healthy eating, working with your gastroenterologist, with a dietitian, to eat things like fruits and vegetables in the form that your body tolerates. If we got sick from food poisoning, that's not the time to eat a salad. So really wanted to incorporate healthy eating that is adapted to where you are in your journey with IBD. You're inflamed, you're controlled, you have a stricture, etc. And also what is very important, and that I want to mention that because we often don't talk about this. We always think about physical stuff we can do. Mental health, right? As you can imagine, having inflammatory bowel disease, having to run to the bathroom, having complication of the disease, needing to see the doctor all the time, having a disease at a time of your life, like we talk about, like this often happen in adolescent and young age, when you are developing your body image, when you are trying to be independent from your parents, when you're trying to fit in with your peers. And suddenly you have a disease where you have to rely on your parents or family member to drive you to the doctor, where you might not be able to participate in activities that your peers are participating on, like field trip, a concert, a picnic, because you're worried to have access to a bathroom. When you have complication of IBD that are physically apparent, whether skin lesion, fistulas, so all this is going to affect your mental, your social development, your psychological development, and your sexual health. As people living with IBD are trying to see how can they make their IBD better, I think it's very important to talk about mental health and how to address that, because a healthy mind is needed to have a healthy body and to be able to cope with the disease and to have a healthier journey.
And this being a chronic disease, it is certainly very important that we get our arms around these individuals and help them with their mental health. I've always said that when we know there's a beginning and an end to something, we can endure it. But when you don't think there is an end, it gets a whole lot harder than to endure it. What is the youngest age that you've seen diagnosed with IBD?
I'm an adult gastroenterologist, so I usually take care of adults or adolescents transitioning to adult medicine, but we are seeing something called very early onset IBD, even in infant. And this is also on the rise, unfortunately. But for very early onset IBD, they seem to be more of a genetic component. So if you have a child, a young child, anybody diagnosed before the age of 6, they should seek care for specialized IBD centers for children and get the right genetic testing and the right therapy. But unfortunately, we are seeing an increase on very early onset IBD in recent years.
And for young mothers out there who maybe have a newborn who's not handling formula very well, don't jump to conclusions, girls, and say, oh my gosh, my baby must have IBD. It could be that they're not tolerating that particular formula and need something a bit different. Is the official diagnosis made by doing an endoscopy and a colonoscopy?
The most common location of the inflammation is the colon. So ulcerative colitis affects only the colon. Crohn's disease can affect the GI tract in many locations, but most commonly the colon or the last part of the small bowel that connects to the colon, what we call the terminal ileum. These are areas of the bowel that are accessible by colonoscopy. So like you mentioned before, Lillie, it's important to realize the common things are most common, right? So that not every GI symptom is inflammatory bowel disease, obviously, but any GI symptom that persists for more than several weeks require attention. So if you're having abdominal pain, diarrhea, blood in the stool, if you're losing weight, if you're developing anemia, if you're having joint pain, eye inflammation, other type of inflammation in the rest of the body, it could be inflammatory bowel disease. So it's important to seek care for many reasons. Whether this is IBD or something else, it's important to take your GI health seriously. And I want to say this especially to the women listening to us, that beside IBD, and I know this is not the topic for today, but I would not be a good gastroenterologist if I don't mention that colon cancer is on the rise also among young people. So we do colon cancer screening after age 50. That limit of age has been changed to 45. So 45 is the new 50. Women are as at risk of having colon cancer than men. And most of people that have colon cancer do not have a family history. And what I have seen, the reason I'm pointing this out, I have seen women presenting to me with abdominal pain, or constipation or blood in the stool. And they were told it's probably hemorrhoid. It's probably because you're pregnant. It's probably that. And often then we delay the diagnosis of colon cancer. So what I want to tell our women out there is that if you have any symptom that lasts for more than a few days, if you have bleeding, if you have anemia that's not explained by your periods, it's important to seek care because it could be something serious going on. Most of the time, like you said, Lillie, benign things are the most common things, right? A hemorrhoid, something like that. But we cannot ignore blood in the stool. We do not ignore that at any age because we are seeing diseases in younger people, serious diseases. So the most important thing is not to overreact, but not to ignore. Anything that's lasting for more than a few weeks, you need to seek medical attention and get the right workup. And yes, colonoscopy is often the first test that we do to look inside the colon and look for any inflammation or any other diseases that could be causing the symptoms.
When someone does have these symptoms, they probably are seeing their PCP initially. How well versed are PCPs in knowing to direct this patient to a gastroenterologist?
That's a great question. And I think PCP have such a difficult job to stay up to date in everything from high blood pressure to
cancer and everything.
Eye health to everything. And as medicine is evolving and becoming more complex, it's very hard to keep up to date with everything. So I think PCPs have a very important and difficult job. I think it's important for people listening that if you feel you're not heard by anyone, whether you primary care, your gastroenterologist, your OBGYN, seek a different opinion if you feel you're not heard. If you are heard, you feel you're in good hands, that somebody's doing the appropriate workup, you found the right doctor, right? The reason I'm bringing this up, and it has nothing to do with who you're seeing as a physician, is that we know from the literature that women are often less heard Even in IBD, we see that they often have less access to IBD-specific therapies. Women's symptoms are often disregarded. They might not get the right treatment. This is even more amplified in minorities and women from minority groups. So it's very important for women to learn to advocate for themselves. If you feel you're not heard, your symptoms are disregarded, seek another opinion. But I do agree that education about inflammatory bowel disease, colon cancer, need to really involve all physicians that are the front line. Emergency room, acute care, primary care doctor, internist, OBGYN that are often the only people some women see. So it's important to have this education. And it's important to say, you know what, I would like to see a gastroenterologist. If your PCP doesn't offer it to yourself, talk to a specialist. It never hurts.
Seek it out. Yes, yes.
Yeah, advocate for yourself.
What are some of the more common treatments for this to be able to hopefully get it into control, recognizing that we can't make it go poof and it be gone, but recognizing it as a chronic disease? What are some of the more common treatments that you do recommend to patients, whether that be a surgical treatment or non-surgical treatment or even both?
Treatment of inflammatory bowel disease, like we said earlier, has really dramatically changed. And we have different therapies that are very effective at controlling the inflammation. So it's important to understand what are our goals of care. We want our patient's symptom to disappear. We want to heal the bowel so you don't have another flare, more symptoms, but also so that the disease doesn't progress into complication or increase your risk of colon cancer. We want you to have a good quality of life. We want to minimize the side effect of medication. And we really want you to basically live life to the fullest as if you did not have the disease. That's how I start the conversation with patient and really have that mindset that there are very few diseases out there actually that don't require chronic treatment. People are often very disheartened that they have to take a medication long-term. But when you think about it, we only have few pathology where you can take a medication for a short period of time and be done. It's mainly infections, right? You take antibiotic for a few days.
Right.
You have a rash from allergy, you put some steroid cream and it's gone. A lot of diseases require long-term treatment. So I say long-term, not lifelong, because there's so much research and progress in IBD that, maybe one day there'll be a cure. Why not? There's a lot of things happening. But what we have now are medication that we need to take long-term. As long as we're taking the medication, we're going to do well. And the type of medication really depends on the severity of the disease, the location of the disease. And so we use different therapies. A class of medications, what we call mesalamine. These are like anti-inflammatory to the gut. There are pills that you take, open up, and the gut act like an anti-inflammatory to the gut. We use that for mild ulcerative colitis. For anything above mild and for Crohn's disease, we have to use medication that actually block certain pathway of inflammation. That's what we call the biologic or small molecules. And the names are scary. When people think about biologic, they think about biologic warfare. They think about, something terrible. And because these...
Well, you are at war with...
We are at war against inflammation, right? But not against your body. And often these medications need to be given by injection or infusion. So people equate that to strong chemotherapy medication. But the reason we give them by injection or infusion is because these are protein. We are able now to develop antibodies that block one of the molecule, if you want, or one of the pathway involved in the inflammation. So it's a very targeted treatment. So that's what the beauty of this. We're targeting the inflammation in a very specific way, as opposed to the old days where all we had was prednisone that target inflammation everywhere in your body. Yeah. A specific way. So different therapies, again, going from mesalamine to medication that modulate the immune system, block certain pathway, and your physician will discuss different medication and choose the one that is adapted to the severity of the disease, to what worked for you before, and to whether or not you have disease only in your gut or if you also have inflammation of other organs.
For women, and you mentioned anemia, so I think about women's menstruation cycle and how that may impact or collide, shall we say, with IBD. Are there certain things also that may happen during pregnancy that would aggravate IBD?
As women, we often experience disease different ways, and IBD can impact women in different ways. So you mentioned menstruation and getting through puberty. So actually in young women where IBD is not recognized, they have IBD, it's not diagnosed or it's not treated properly, there's often a delay in puberty, a delay in getting menstrual periods. So it's important to control the disease properly. There can be a delay in growth. And we know that our capital of bone strength happens around age 16 and 18. So this is when we get the peak of our bone density, right? And after that, everything goes downhill for women.
Yeah.
when IBD is diagnosed at a young age, it's important to treat properly so the bones are strong. So later we're not dealing with osteoporosis. But pregnancy is very important to talk about because, of course, when we're pregnant, we're worried about taking any medication. We think it's going to affect the baby. A lot of women actually living with IBD are worried about getting pregnant and passing on the disease. Babies, that's why I said it's a higher risk, but it's not a huge risk of your child having IBD. A lot of women avoid intimacy because of IBD. As you can imagine, if you're having diarrhea, if you have urgency to run to the bathroom, if you have other things, you might not want to have sex or feel intimate with someone. But when we get to pregnancy, the most important message for people listening is that it's very important to have the disease under control before and during the pregnancy. A healthy mom is going to lead to a healthy baby. That means is that we need to stay on the medication that is controlling IBD and not stop them. And most medication that we use in IBD are safe during pregnancy and they are safe for the baby. They do not increase the risk of malformation in the baby or abnormality in the baby or issues in the infant. So it's very important to discuss your plans to get pregnant with your doctor. So I'm like the gastroenterologist. I'm like, in addition to your spouse and your mother-in-law, you need to talk to me about any pregnancy plan. I need to be involved from the start. Because like these are conversations that are important because what happens, somebody find out they're pregnant, like, oh my God, I'm taking this medication. I'm going to stop. It can baby. And what happens, they hurt themselves. They go into flare and it's a flare that's going to hurt the baby. You can lose the pregnancy. You can have premature baby, which has a lot of complication. You can have a baby with a low birth weight if you're flaring. So it's very important for us to control the disease off steroid before pregnancy and keep that disease under control. So it's important to have that conversation ahead of time. And again, knowing that most medications that we use to control IBD are safe during pregnancy, should be continued throughout the pregnancy. So you are healthy, you have a healthy baby. And when the baby is born and there are sleepless nights and you need all that energy to wake up, breastfeed or bottle feed or take care of the baby, you are in your maximum optimized health to take care of your infant and enjoy that time of your life.
Are the medications expensive?
Oh my gosh. Don't get me started on the medical system in this country and medications. That's a other podcast. A lot of the medication that we have are very expensive. The bad news is that often insurance gives us a very hard time to get the right medication for the right patient. And that's a constant struggle. I'm sure you've heard from other physicians and people living with any disease, the burden of prior authorization, begging the insurance to get the right medication for the right patient. So that's a problem. Thankfully, a lot of pharmaceutical companies offer a way to mitigate the expenses, the copay for these medications, but they are expensive. We know that in other places of the world, they're not as expensive. So that is a whole topic. It's important to talk to your doctor if you have these concerns. Everybody has their own pride and they don't want to bring up financial issue, but please know that your doctors are there to help you and find different way to cover costs that might not be covered by your insurance and your payers. So it's important to be open to this and not stop a medication or not start a medication because you're worried about cost. There are different things that we can do to help.
We know with chronic diseases that patients are shy about saying, gee, I don't have this extra cash sitting around somewhere. And then they're thinking about, I'm going to be taking this for quite some time. And we do need to speak up and say, if you anticipate that you may need help, first of all, you're not alone, that there are many, many, many patients who need financial help with paying for these types of medications as well as other medications. And let's see what we can have the pharmaceutical company do with drug discounts, but also looking at their, quite frankly, their prescription plan that they may have through their employer. They're going to be renewing whatever their health insurance is going to be probably in October or November for the coming calendar year. I know I always tell patients now is the time to take a look and see, does that prescription plan cover and not cover, so that when you have several options, let's choose the one that's going to be the most beneficial for you. And it may not be the one you've been using for the last 10 years. So We've gotten women into having a menstrual cycle and then we've gotten them pregnant. Tell me about menopause and what can happen as a woman is approaching and then going through menopause, because we certainly do worry more about osteoporosis with her estrogen, progesterone levels bottoming out, shall we say.
Yeah, it's very interesting that menopause doesn't seem to affect the severity of IBD. So if you look at women during menopause, it doesn't seem that IBD get worse or better, or it seems like it kind of all stay the same. But you pointed out to osteoporosis, right? And women are at high risk of osteoporosis, and women living with IBD, especially if at some point they were malnourished or they use steroids or they had decreased physical activity, right? When you're sick, you're not pumping money, which is important to build the bone health. Often also people living with IBD would avoid milk and milk products because it bothered their stomach. They having less of calcium and vitamin D intake. So all these factors increase the risk of osteoporosis in women before and with menopause. So very important to get your bone density scan and treat that appropriately. But also it's very important to prepare for that, right? So before hitting menopause, or even if you're already in the menopause, to really think about your bone health. One is controlling the disease, but also physical activity, getting calcium and vitamin D if milk doesn't agree with you, an alternate source or supplements, minimizing the use of steroids when we don't need to. That's why it's important to use effective therapy, and really talk to your doctor how you can optimize your bone health. After that, in terms of menopause and living with IBD, it's important to again realize that IBD can develop after menopause or get worse at any time of life, not really related to menopause. So it's important to recognize those signs and symptoms and seek care if need to. The other thing is that if you've had disease for a long time, so it has nothing to do with menopause, but let's say you were diagnosed at 20 and now you're 50, it's important to realize that having ulcerative colitis or Crohn's colitis can increase our risk of colon cancer. People living with IBD for more than 7 years need regular colonoscopy, which means that if you were diagnosed at a younger age, you're not waiting until age 45 to start your screening. You're starting your screening earlier. So it's important to be aware of that.
How often, because normally we'd be looking at, from a colon cancer perspective, we'd be with no known risk factors, we'd be looking at every 10 years.
Correct.
I'm sure it's not a decade between.
No. Depending on the patient, the extent of the disease, how well the inflammation is controlled, and other factors like family history or whether or not we found a polyp at some point, the recommended interval of colonoscopy for people who've been living with IBD for more than 7 to 8 years is every 1 to 3 years. Again, I've had my colonoscopy last year, my screening colonoscopy. And as I was drinking this prep, I'm like, God bless my patients living with IBD, having to drink that every year or every 2 years. Talk to your doctor about what prep works for you better. I have a couple of preps that I like. Some taste less evil than others, or less volumes than others. So depending on if it's like a short, smaller volume that you feel you prefer, or a taste that's less salty than others, talk to your doctor, because we don't want people to avoid their surveillance colonoscopy because of the prep. So see what works best for you. But yeah, the interval is more often. It has to be very careful exam, looking for subtle changes. The prep has to be really good, because people with IBD can develop cancer without developing a polyp first. We're looking for very subtle changes of the lining of the colon that could suggest that something is going on.
And when you mentioned it needs to be a good prep, I know patients who have made the personal decision, I am not going to finish this prep, and nobody will know it.
I'll know it.
You'll know it. That camera going up your bottom is going to show that you did not do the full bowel prep, because we really need everything clean in there in order to find what you need to see.
Yeah, absolutely, Lily. It's not easy. I totally recognize it. But since you do it right. And, I'm going to say something. Women do it right. Women are just so good about taking the prep and making sure that they don't want to be embarrassed. And it's very, very, very unusual for me to see a poor prep in women. So thank you for all the women out there. Women are like overachievers. We always think we have to do more. But the reason it's important is that you're getting this test done anyway. You want it in good quality. There's no point in missing polyps or lesion or come back to do it. So do it right. But kudos to all the women out there. Women always do a good job. It's like spring cleaning, right? We are cleaning our closets, right? We clean our colon well.
Is there also a connection with hyperthyroidism?
That's a good question. So inflammatory bowel disease can be associated with other immune condition or inflammatory condition like psoriasis, arthritis, other disorders. We see a little bit more sometimes of celiac disease or eosinophilic esophagitis. I'm not absolutely aware of a connection with thyroid disease, but thyroid disease are common in women also. So they can coexist. doesn't necessarily mean that there's a link. They coexist because thyroid disease, autoimmune disease are common in women. So this can coexist in a woman living with inflammatory bowel disease.
Recently, there was an article published, and I think it came out through NIH, showing that there may be a connection between IBD and Parkinson's disease. Are you seeing that?
So there's recent data that's really eye-opening on what chronic inflammation can do to your body. We often think about organs as functioning in silos, right? What's going on in the gut is affecting the rest. And what we're recognizing now is that having chronic inflammation actually affect the entire body and probably damage the vessels in our body or affect distant organ. So there's been a relationship with Parkinson, maybe with dementia, with Alzheimer. There's been a relationship with cardiovascular health. People with chronic inflammation like IBD that's undertreated have also a higher risk of having strokes or heart attack. So we are now starting to understand and looking into these things. And I think it's very important when I tell people with chronic illnesses, why we're treating that. You're not just treating the gut, you're also treating your whole body, because chronic inflammation puts you at higher risk of disease affecting the brain, the heart, other organs, whether it damaged the vessel, whether the chronic inflammation affects the tissue itself, or whether having chronic inflammation in the gut affect, like we talked about, the gut microbiome is not healthy.
Right.
And recognizing that an unhealthy gut microbiome not only affect the GI tract and increase the risk of GI diseases, but also other organs, including the brain, the heart, and other conditions.
Yeah, and you mentioned liver earlier. There also may be a correlation with some lung disorders as well. So making sure that we're taking care of our gut needs to be a priority, because it has a domino effect, doesn't it, on other organs in our body. And then that takes us back to anxiety and mental health. You can get in that catch-22 and not be able to get out of it. And I'm sure that some patients, what they would really like to do is to come live with you. And just have you there all the time saying, is this okay to eat or is that okay to eat? A lot of our listeners are mothers of tweens and teens. And of course, that age group kind of lives at fast food restaurants if they're allowed to. Can you give some advice to these moms so that we can get youngsters, I'm going to say, on the right track, on the right GI tract for a diet that is going to hopefully minimize the ability for the gut to go in the wrong direction?
It's very important to realize that good habits start young, right? We can't expect to give our kids chicken tenders and let them spend hours in front of video games or their screen, and then as adults tell them you have to eat salads and grilled fish and go exercise. Healthy habits start early, and it's important to make it fun and make it part of our life. Few things that I think is very important for gut health. One, fruits and vegetables and unprocessed food and lean meats and good fat. So by good fat, I mean things like avocado, salmon, almonds, olive oil. It's not the fried stuff. It's not the donut. It's not that stuff. And grains and seeds. So seeds like nuts and oatmeal, and then legumes, right? The beans, etc. What we want to do is make that food fun and healthy and attractive to people. And the earlier you do that, the better. And it's really how you cook at home and really encourage cooking. So for example, in my house, I just don't buy that stuff. I don't buy sodas. I don't buy chips. In terms of sweets, of course, I'm not perfect and I don't pretend to be. And I love sweets and I crave good stuff. But we choose like chocolate, for example. Chocolate is actually a good probiotic, believe it or not. So not too much of it, but just enough. Dark chocolate is a good probiotic. Do we treat ourselves for something good from time to time? Yes, but it cannot be like part of our daily diet to eat potato chips and hot dogs. So don't bring it at home because it's there. It's going to be tempting. Involve kids in cooking. Often, kids are proud to what they've done. And even if you're grilling a burger, grill some mushroom with that, some red peppers, yellow peppers, onions, and then put it on your burger. That's your vegetable, right? I often sneak in my vegetable in my lasagna, right? I grate the carrots, the zucchini, the yellow squash. It's all grated in my tomato sauce. And they're eating it up without realizing they're eating vegetable. But it's really developing that sense of enjoying a vegetable, enjoying a piece of fruit. You go hiking and bring with you snacks like dark chocolate and fruit. And they're all going to want the fruit because it has water in it and they're thirsty and they're going to eat that apple with great appetite. So it's important to have these habits, but also it's important to have these discussions, right? Teenager can be difficult. I have 2 teenagers now at home. But I think when we talk to them as adults and explain things to them, it's important to explain why we're doing this, what's going on, and how it's important to love and respect our bodies, especially like for young girls and young women, that this is part of you respecting your body, how you dress, how you act, but also what you eat and how you nourish it.
I like that.
Loving your body. You're doing something good for yourself, and kids want to fit in, but also they want to feel independent and cool. You're showing independence in your thought process by making smart choice in what you're eating and what you're doing. It's like we said, not just food, it's physical activity, it's good sleep, it's good habits, and getting outside. There are actually studies showing that kids that play outside in the dirt have less risk of having IBD and other autoimmune disease growing up in a neighborhood where everything is asphalted and there's no play area. There are even studies showing that in households where dishes are cleaned by hand, there's less IBD than when dishes are cleaned in the dishwasher, because the dishwasher gets to very high temperature, kills all the bacteria, versus if there's a little bit of dirt left, a little bit of left behind, it's actually good for your gut. When my kids were growing up, I'm sure a lot of mothers thought I was crazy. If they dropped something on the playground, like a toast or something, I'm like, pick it up and eat it. 5-second rule, because excessive hygiene, we're killing all that bacteria, right? Not in the sand and the ground. We're not nourishing our gut with the good type of bacteria that we need. So it's important, of course, wash your hand before eating, take a shower every day. The basics should be there. But the obsession about cleaning everything, not picking anything from the floor, super high temperature, boiling those bottles, boiling everything, I think it's taking our gut is a little bit sterilized and not getting exposed to good bacteria that promote a good, healthy immune system. So get dirty, get outside, garden, play outside, go on walks, run outside, as opposed to everything indoor. Everybody has an indoor gym now. Be outside as much as possible, eat healthy, sleep well, but also have fun and laugh and have that community around you, have those social interaction. I think that is so important for our mental and our physical health. Living alone, living in isolation, living with your phone is not healthy at so many levels. So yes, it's social interaction, sharing meals together at the table where there's discussion and we're talking about the day and project and everything. You eat good stuff without realizing that you're eating it. But also, I think emotionally, physically, mentally, it just creates a healthy body and a healthy mind. And that's very important.
That's excellent. What a wonderful summary today. Thank you so much for joining us today, Dr. Charabaty. I want to encourage all of the mothers out there and grandmothers and a few great-grandmothers that it's never too late to start eating a healthier diet. It's never too late to start physical activity. We don't expect people to buy a gym membership, but if you get out and power walk with your neighbor this afternoon, you'll be doing a good thing for yourself and a good thing for your neighbor. Thank you so much.
Thank you, Lillie, for having me. I really enjoyed myself today.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.